Hi everyone, welcome to the October WH&Y webinar. We've unfortunately encountered a couple of technical difficulties and our host Philippa Collin hasn't been able to get in, so I'm jumping in. I'm Sharon Medlow, I'm the Research Translation Coordinator for WH&Y and really excited to be welcoming Ursula today. But before I do that, first we'd like to acknowledge our funding partners at our partner universities across Australia. I'd also like to acknowledge the traditional owners of country throughout Australia and recognise their continuing connection to land, waters and culture. We pay our respects to their elders, past, present and emerging. And today I'm joining from Darug land. It'd be great to see what lands you're all joining from too. You can pop that over there in the chat. We'd really love everybody to come and check out our community of practice. We just launched this section of the website fairly recently. And you can find our past and upcoming webinars in there and also a huge library of resources. A little bit of housekeeping. So as you'll be able to see already, your microphone and video are turned off, but we really would love it if you'd put something in the chat, say hello, let us know you're here and where you're coming from. And that's also the place where you can enter your questions, and Ursula will answer those questions after her presentation. So here's Ursula. I'm very, very excited to have Ursula on today. She's a Cancer Institute New South Wales Early Career Fellow, a Senior Research Fellow and Deputy Head of the Behavioural Sciences Unit at UNSW. This is the largest psychological research group in child and adolescent cancer in Australasia. Ursula is also the clinical psychologist for the Sydney Youth Cancer Service, which is a leading team in the treatment and clinical care of adolescents and young adults with cancer. So Ursula's focus is on applying evidence-based psychological models and methods to understand and address the mental health implications of cancer among adolescents and young adults with cancer. So welcome, Ursula, and we're really looking forward to hearing what you have to say.
Thank you so much. I'm thrilled to be joining you all, and I'm excited to see as well that we have some international people listening in from Norway and Myanmar. That's so exciting. So thank you for coming online. I am Ursula, and I'm going to be talking about how we can do better at difficult discussions with young people with serious illness today. And this has been an emerging sort of research and also clinical passion of mine for the last few years. And I also want to briefly pause to show my respects and acknowledge the Gadigal people of the Eora Nation, who are the traditional custodians of the land I'm dialing in from, and extend my respects to elders past and present on which this meeting takes place and from the many traditional lands that we're dialing in from. So I also want to acknowledge that what I'm going to be sharing today is, things that I've learnt and gathered wisdom from many amazing collaborators and mentors and clinician researchers in the field who I've been fortunate to learn from and be influenced by and even collaborate with some of them. And hopefully some of these names and faces may be familiar to some of you, but just some amazing people working in this space as well. So I want to tip my hat very heartily to all of those people. So today's focus is going to be thinking about, I suppose, developmental considerations on having difficult conversations. And in preparing this talk, there are so many difficult conversations that we can think of, but I've focused today on the sort of difficult conversations that can be important and relevant when it's not clear that a young person's illness is curable, or it's not clear how treatment's going to go. So, we're kind of going in the terrain of sort of some of those palliative care conversations, but, fully acknowledging in the world of adolescent medicine and adolescent health, there are so many different kinds of tricky conversations that can be important. So hopefully some of what we talk about today will still have broader relevance across those different topic areas as well. I'm going to be focusing particularly on some of the implications for clinical practice from the research, and being a clinician researcher myself, that's something I feel very strongly about, that whenever we're doing research, we need to be looking at how we can bring that into clinical practice as effectively and as rapidly as possible, whilst following evidence-based practice to the extent that we can. And I want to introduce you to some new and emerging tools today as well that can help support some of these conversations, and think about what next and what do we still need to do in this important area. I wanted to mention a couple of caveats at the start. So my focus is on adolescents and young adults, and so that's what the research and the data that I'll present on today primarily focuses on. I have some data on parents as well, and we always need to be thinking of in the context of the family unit as well. But I would say at the moment, the research to date has mainly focused on adolescents and young adults. There's less that has looked at the family system as a whole. The other thing that I want to mention is that a lot of the data that I'll present today has more so focused on kind of the medical side of communication in the health system. But as I'll talk on later, it's really vital that we have the whole multidisciplinary team involved in these sorts of conversations. And I'll talk a bit more later about how that could look and how that could happen. But I'd say some of the research to date has tended to focus on more some of the conversations that can be led by our medical colleagues, which is a really important part of it too. So we know, everyone here already knows without me going over it really, that adolescents and young adults are a special group. And we know that for a young person, getting any kind of serious illness, particularly one that could be life-altering or life-threatening in nature, you could think about this as being developmentally incongruent. So what do I mean by that? Essentially that it's not kind of part of the typical life script of a 16-year-old or a 25-year-old. Most of them aren't kind of walking along in their daily lives, going to school and hanging out with their friends. Most of them aren't expecting to suddenly be diagnosed with a really serious illness. So what that means is that it's kind of at odds with what they would be expecting to encounter in their lives. It's quite rare, relatively speaking, and it also means that they are unlikely to have many friends at the outset who have been through a similar thing. So unlike someone in the later years of life, 70s, 80s, 90s, by that time of life, it's quite common that you might know or might have observed other close friends and family who've been through serious illness experiences. Young people don't so much have that life script and that kind of that framework to understand it through and to fall back on. We also know from the psychological perspective that the adolescent and young adult years are already the peak time or the peak age of onset for mental health disorders to emerge. So cancer and illness aside, the teenage and the young adult years are the typical time when we would most see people's anxiety, depression, and those sorts of things first emerge. And so that means that we need to just be bearing in mind how the illness experience interacts with that and how it layers on top of that, and in thinking about our psychological care and support of young people. It doesn't take away from their resilience, but it just is a factor that we need to think about. And from a systemic perspective, we know that adolescents and young adults do straddle the paediatric and adult health systems in Australia and many or most places in the world, really. So me here at Sydney Youth Cancer Service, that position involves me being cross-appointed across the Children's Hospital and the Adults Hospital next door to be able to look after those young people. And the practical impact of that is that we have young people dispersed across different settings, and in any one given setting, they can be a minority, so that there isn't necessarily a huge or a critical mass of them. And what that can also mean is that at any one given setting, they may not necessarily be the kind of primary focus or the primary population that the healthcare teams are focused on caring for. So that is, an adult oncologist may not treat that many 20-something-year-olds compared to the number of 40, 50, 60, 70-year-olds that they treat. And likewise, in the children's hospital, the teenagers are just a portion or a fraction of the broader kind of childhood population. So that has implications when we're thinking about how prepared, how ready, how skilled, how confident health professionals feel in taking care of young people. And when we come to the pointy end of care, when things are tricky and when discussions are harder, that can sometimes be where those challenges emerge, where it's maybe challenges in not knowing or not feeling confident about the best ways to provide that age-appropriate care. So this is a quote that I often come back to, and it's by David Fry, who's a palliative care physician in Canada, I believe. And he's written before that for the seriously ill adolescent, or even the dying adolescent, for them, adolescence is a paradox of emerging capabilities and diminishing possibilities. So it's that juxtaposition, or that kind of the kind of duality of adolescence being that kind of, on the one hand, time of enormous opportunity and flourishing and growth and looking to the future and planning your future lives, and at the same time, the ways in which illness and serious illness can close some of those doors and windows temporarily, and for some, more longer term. And so I think thinking about this from a developmental perspective, we need to situate ourselves in that place so that adolescents would normally be, very much future focused and planning their futures. So I put this picture up because I think it's worth reminding ourselves about how much of a foreign land the healthcare system can feel like for adolescents and young adults, especially, for example, I work in cancer, and if a cancer experience may have been the first time that they've been diagnosed with something quite serious, quite life-threatening, it might be the first time they've set foot in a hospital. And unfortunately, we know that some parts of our adult hospitals still look a little bit like this. Some waiting rooms, young people are going to be, less than half the age of the next youngest person in the room with them in the adult system. And so let's think about what's the experience of that for the young person, how isolated they might feel, how well prepared they feel to navigate that new terrain, to speak the foreign language that the doctors and the nurses seem to be speaking. What's the impact going to be on their kind of stress response? And all of that is sort of really important context for us to be thinking about when we meet with young people and approach them to talk about any aspects of their care. I think, by now there's also a lot of research to show that there are kind of multi-layered impacts for young people going through serious illness. And so, we can start by thinking about the developmental impact of getting a serious illness at that time of life, at the time of life when they are, going to school, planning for uni, getting jobs, developing romantic relationships, all those sorts of critical things. And then there's the layer of distress that can come on by, for example, something like cancer being layered on top of that, how that halts those life progression to those life milestones and life events, how that alters their sense of self and their sense of identity, their feelings about their body, their trust in their body. And then there's the health system piece, like I was talking about before. So this foreign land that they find themselves in, and the foreign land where, unfortunately, there can sometimes still be instances where young people can seem to fall through the cracks. And obviously, in Australia, in recent years, in the past decade, we've had, for example, the development of the youth cancer services, and that's kind of where I work, and that's mirrored developments in the rest of the world as well, where there's been this increasing attention on adolescents and young adults, and how do we provide them with youth-friendly, age-appropriate care. But still, we know that many young people, live far away from hospitals where there might be a youth cancer service, and so there are likely still some young people who do fall through the cracks and may not be necessarily receiving this age-appropriate care. And we know that's the case overseas as well. So let's dive in and think a bit more about having some of these difficult conversations with young people with serious illness. And we know some already about what young people want. So if it's the case that it's not clear whether their illness might be curable or how they're going to respond to treatment. And research, over many years has already indicated that most adolescents are aware of more than their parents suspect. So there was this seminal study by Myra Bluebond-Langer back in the 80s. And, I think those of us who are clinicians are kind of aware that young people are pretty cluey as well. So, that idea that you can try, but you can't hide much from young people. They're pretty switched on. And we also know from a number of studies that young people are actually quite capable of complex decision making as well. And that's perhaps something that, increasingly with youth-friendly cancer care and youth-friendly health services, we may be giving young people more of that credit to be more empowered to actively take part in health decisions. But it's really important that we do give them that opportunity, given that they are quite capable of it, or participating to a degree when they want to. Studies have shown that almost all adolescents and young adults, or AYAs, say that participating in advanced care planning, so that's conversations about medical treatment, medical choices, goals of care, would be helpful. And I'm not sure whether that's a finding that necessarily everyone would expect, and we're going to keep diving into that. And so this pilot study, again, this was done almost a decade ago now, and they developed a structured advanced care planning guide for adolescents with cancer. And they asked them in this pilot what it was like for them to go through that guide. And 24% of the young people said, yeah, it was sad to have conversations, early conversations about the possibility of poor outcomes, the fact that their cancer might not be cured. But 71% said the conversations were worthwhile, and 91% said they were helpful. And so I think that, we can often feel quite worried or scared, perhaps even, about this idea that we might make people sad or might make them upset. And I think, this is just one study to show that, some young people may feel sad, and they may also find it worthwhile and helpful. And I think another point for us to consider is that maybe it's quite understandable that talking about some of this stuff is sad. It is sad getting cancer when you're 16 or 21 anyway. So I think it's important to be able to hold those two things in mind. Just for the question on the chat there, I can answer that really quickly. Youth cancer services in Australia, that's 15 to 25-year-olds, but the age ranges are defined a little bit differently overseas. So what do we know about what parents want? And so many of you in adolescent services would also be providing a lot of support for parents. And again, generally parents want more information than we may possibly realise or assume. So these researchers have done some fantastic longitudinal studies where they've looked at what kinds of prognostic information parents have wanted over time. So prognostic information related to the likelihood that treatment will be successful, the likelihood that their young person may respond well or be cured. And so in this large study, 382 parents of children and adolescents, the vast majority of them wanted as much detail and prognostic discussions as possible, both at diagnosis and up to 12 months later. So those preferences persisted, interestingly. And this is a really useful table, I think. So you can see here, they looked at these preferences over time at diagnosis, at 4 months, and again at 12 months. And they got to choose, I prefer not to hear a lot of details, I want to hear details only in certain situations, or I want to hear as many details as possible in all situations. And you can see that at all time points, it was vast majority that wanted as many details as possible in all situations. And they looked further in their analyses to see what predicted wanting more information. And interestingly, they showed that a young person having a poorer prognosis actually predicted the parents wanting more information at 12 months, not less. So I think that goes against the idea that, bad news or things looking not great, that a parent might be wanting to kind of not hear it and kind of bury their head in the sand. In this study, it was not the case. And what they were able to show was that the degree or the extent of earlier prognostic discussions was the best predictor of parent satisfaction with care at 12 months. So how sort of detailed and how much context they provided in those early discussions was really important. And so I think that what that tells us is a couple of things, that those sort of day one or, first week, first fortnight kind of just diagnosis and staging discussions, they're very important. They obviously leave a mark in an ongoing way, but they're also not enough. And so parents continue to want more information over time, which makes sense because cancer, like any illness, is quite a dynamic and long-term thing. So, I mean, why do we need difficult discussions? So we kind of haven't addressed that point yet, but why would I be bothering to talk about this in the first place? Well, across a number of studies, we know now that not talking about these conversations can lead to some poor outcomes for adolescents and young adults themselves. So it can lead to them having poor anxiety, or worse anxiety, I should say, pain that's potentially not managed as well as it could be, not dying where they wish to. Now that one is an interesting one because I think in the literature we actually don't have much solid data to indicate strongly where adolescents and young adults typically prefer to die. And of course all of these things are very individual anyway. Anecdotally, certainly we know that some adolescents would prefer to die at home, as would some adults. And we've also had the case in our clinical practice that we have some young people who form really strong, long-standing bonds with their youth cancer service, and it's actually been their preference to die in hospital. But regardless, if we don't have the conversations, we can't know what their preferences is. And if we don't know their preferences, we can't actually plan and put things in place in enough time to make sure that that happens. So they do remain at risk of not dying where they wish to or they would prefer to. And there's a risk of them dying in a state of emotional isolation. So really just the sense of, them not feeling like people knew where they were at and what they were feeling and thinking about everything. There is also some data to show that parents can be at risk of regrets later on. So when the adolescent is older and when they've sort of the adolescent has known what was going on, that parents can be concerned and have regrets if they haven't been able to have those conversations with them. And again, I think we need more data, but I think we could be concerned that if parents are left with these kind of concerns and regrets, that maybe we're going to be placing them at greater risk for things like complicated grief or prolonged grief later on, for them not having been able to have those conversations. And so I've talked about adolescent preferences and parent preferences, and I think it's really important to note that they can be quite different. So parent perspectives and adolescent perspectives are not necessarily the same, and this is why it's really important that we can't just use one, like a parent's perspective or decision, as a proxy for the other. And so this paper is a really excellent read. It was out in 2020, and they did a beautiful study looking at the congruence between adolescents with cancer and their families regarding a whole number of different things related to their values, their goals, and their beliefs around end-of-life care. And I actually just want to quote the paper directly because I think it's quite powerful. They said family members' understanding of their adolescents' beliefs about the best time to bring up end-of-life decisions was poor. So 86% of adolescents wanted early timing. So before getting sick, while healthy, when first diagnosed, when first sick from a life-threatening illness, or all of the above. But only 39% of families knew this. So 86% wanted it, and only 39% of families knew it. So I think that kind of highlights why it is really important that we are hearing adolescent voices and young adult voices directly from themselves, that we're not kind of trying to infer or guess or get a hunch from mum and dad, but we actually find the ways to make space to hear the adolescent's voice for themselves. And I've talked about some of the risks of what happens if we don't have these conversations. But I think it's also really important to think about what are the potential gains for having these conversations as well. And I know that a lot of people hear, this kind of talk and feel it's quite doom and gloom, which, in a sense, there is some kind of stuff that can feel a bit more confronting in some senses, but having these conversations is the thing that enables us to help young people live their lives the way they want to, whether that life course is going to be months away, weeks away, years away. This paper here is a beautiful one a beautiful qualitative study exploring young people's experiences and perspectives on what makes life meaningful for them. And we have to remember our young adolescent and young adult patients are living their lives until the day that they're not. And so, we've got all our different roles and all of our different professions in the hospital. But at the core of that, if we think back to the start where I was talking about, adolescents and young adults is this really burgeoning life stage where they should be doing so many different things and want to be doing so many different things. We need to put our healthcare priorities and kind of considerations in the context of how we can be helping young people to live their lives as best as possible and in the ways they want to up until the day they die, whenever that is. So I think there's a lot to gain in terms of helping support young people to live well through having these conversations. And we can't kind of help facilitate those choices around quality of life and how they spend their time and how we care for their symptoms if we don't know. So what do we know about what's actually happening? And this is data from the States and also from Australia. And well, we know that probably a lot of the time the conversations are happening too close to death and not well documented. And they don't occur spontaneously. And so this is one of the things, I suppose, as health professionals, and perhaps earlier career health professionals particularly, who may not have as much experience with this, can be quite anxious about the idea of bringing up, but we know that parents and families aren't going to do that for us. So without intervention, some studies have reported it might occur spontaneously in 3% or less of families who it would be relevant for. So families and young people are really looking to us to open that door for them. And I think in terms of thinking about the power dynamics in the healthcare system, I think it is still often the case, even in the best kind of shared decision-making kind of patient-centered models, there is still that power dynamic where parents, families, young people are often taking their cues from the team about the direction of things, about what's important for us to be talking about today, what's not relevant for us to be talking about today. So we really need to bear that in mind. So some thoughts about what all this means for clinical practice. I think, one of the big things for us to think about with this communication is that there's sort of almost two parts to be conscious of. There's the content, or the what of what we want to talk about, and then there's also the process, how we go about it. And so I think oftentimes health professionals can be quite concerned about what they're going to say and how they're going to say it. And so I suppose that's a little bit of the content. Do I bring up this? Do I bring up that? Do I talk to them about pain medication? Do I introduce them to palliative care? And then there's all this stuff around the process. So how do we do it? When do we do it? Who's leading that conversation? What words are they using? How do you set up the consultation? Who do you invite along? Do you give them forewarning? All of those sorts of things. And we reviewed the literature recently because we just didn't feel like there was an awful lot around to help guide that from the clinical practice side of things. And so we tried to look at what the implications were for the content of what you say and also the process, how you say it. And so we kind of developed this model looking at tying together all the different aspects of what I've been talking about. So the developmental stage of where adolescents are at, their cognitive, social, and emotional capabilities and capacities, medical components of their care, existential elements of palliative care and end-of-life care, psychosocial considerations, family, and ethical, the ethical considerations around decision-making and end-of-life care. And in this model, we really looked at the evidence for each of these things and how this informs these sort of three kind of concepts. So the timing of when you have these conversations, the content of what you talk about, and facilitation. So who's raising the conversation, who's opening the conversation, who's supporting that conversation. And, thinking around, the developmental piece and the psychosocial piece, particularly in terms of what goes into youth-friendly care. And I'm happy to share the paper with anyone who's interested. But, one of the things that came up quite strongly from the evidence is that it's likely not any one profession's job to be having these conversations or to be facilitating these conversations. And in actual fact, from a relational and developmental perspective, in terms of youth-friendly care, we know that it's likely to be the most important that the young person be able to have these conversations with whichever member of the healthcare team they have the greatest bond or rapport with. And so for some young people, that may be clinical nurse consultant or a care coordinator. It could be their doctor, it could be their psychologist, it could be a range of different people. So we need to think about centering it around what that young person needs and what's going to be most helpful for them. And then in terms of timing and content and facilitation, we're going to talk about this a bit more, but I think, all of the best thinkers on this topic, I would say currently, the leaders, the global leaders in doing this research, I think would say that it's not a one-time conversation, and it's actually a kind of a dynamic process that happens over time. And so it's to do with some of that early seed planting and that early ways that even from diagnosis, not that we're launching straight into talking about, death and dying or anything like that at diagnosis, but what are the ways at diagnosis that we can be starting to plant some of those seeds that are going to mean that from a relationship building perspective, that we're laying those foundations for having some of the trickier conversations later on. So this is a really excellent paper that I can highly recommend for anyone. And Abby Rosenberg, Joanne Wolfe, Laurie Weiner, Maureen Lyon, and Chris Futner, they're all pretty much giants in the field. In doing this work. And, they talk about in this paper some of the challenges and opportunities with having these conversations with terminally ill adolescents, and how you actually do that. And, again, with this idea of seed planting, they talk about what are the ways that you can flag for a young person from the very early meetings that you have with them, that this is a relationship in which, I'm going to be honest with you when I need to be, and I'm going to have the conversations with you when I think there's something important for you to consider. And so they kind of suggest that early on, you could even say something like, something you should know about me is that I'll always be straightforward and tell you the truth as best I know it. And that's really, all you'd need to say early on. And then later on, you've planted that seed and you can say, remember when I told you how I'd always be straightforward and tell you the truth? Well, now I'm afraid I have some difficult news. So you've planted that seed and you've come back to it. And, it's all of these things that we can do that help give young people an anchor and help give them a sense of certainty and security amidst all of the uncertainty that serious illness involves. This is another really lovely paper led by Laurie Weiner and Seema Zade, so Laurie Weiner, I'll talk a bit more about her in a minute, but she's led a lot of really important work developing this Voicing My Choices tool. And in this paper, they again give some really helpful language about how you can just be able to introduce a tool like this, a communication guide. And so they say, well, although we're hoping that this next treatment or medicine will be helpful, many people your age have told us that they've found it helpful to have a say about what they would want or not want if treatment doesn't go as expected. In fact, people your age helped create a guide so they could put down on paper the things that are important to them. And of course, like all of these things, everyone has their own clinical style and approach, but I think it's always helpful to get a sense of possible language that you could be able to use. So it's about opening doors. And I think, the one thing that I think comes up repeatedly is that we may need to open the doors many times and in different ways. And we also need to be really listening carefully to when young people or families may kind of nudge at the door as well and want us to open it. And I think that sometimes we're talking about a lot of different things at the same time and balancing a lot of considerations at the same time. So this is a concept from psychology that I really love in thinking about this. So it's the idea of dialectics. So the idea that two things that seem exactly opposite can be true at the same time. So one of the things that people often have concerns about having these conversations is that if we talk about the potential that treatment might not work, then we're going to take away all their hope. Like it's two completely opposite things that are completely incompatible. And I would think that actually we need to be able to talk about the two things as parallel tracks almost. We can talk about what happens if treatment doesn't work, and we can also still hope for the best. So I think these are really helpful things for us to be thinking about. There are some great questions there that I might come back to a bit later on, if that's okay. I want to talk about some tools now, and I'm going to come back to the idea of support and disagreement as well. But so this is that Voicing My Choices tool that I mentioned about. So this is Laurie Weiner, who I had the pleasure of interning with and working with when I was a PhD student. She's at the National Cancer Institute in the States. And so many, many years ago, she co-designed this communication guide for adolescents and young adults. And it's not a cancer-specific tool. So it's actually, she originally designed it with adolescents with cancer and HIV, and she's since studied it in cancer, HIV, and cystic fibrosis. And so this is a communication guide designed for and by AYAs. And it's really an advanced care planning guide designed to be a communication tool, so to scaffold many of these important conversations. It has a range of different sections about how I want to be comforted in terms of symptom management, and also things to do with legacy. So if I were to die, how I'd want to share my belongings or how I'd want to be remembered. And they've recently studied this in quite a large study across a number of sites in the States. This was published last year in 2021. And in this study, they really aimed to look at the perceived helpfulness of this communication guide and to determine whether engaging in advanced care planning using the Voicing My Choices tool reduced anxiety, increased acceptance of illness, and improved communication about advanced care planning with either family or healthcare providers. And so they looked at 18 to 39-year-olds. So like I said, they have a slightly different age range to us with cancer and chronic illness. And they looked at things like communication, end-of-life anxiety, acceptance of illness, social support. And so what they did is they used an interview protocol and they looked at young people's perspectives pre and post the interviews. And then they also followed up with family and health providers as well. So they included 129 participants, which is a pretty nice sample size. And they found that 50% had not previously discussed their wishes or preferences for end-of-life care with a family member, but 47% of those did share their Voicing My Choices pages at follow-up. 77% of the young people had not previously discussed their wishes or preferences with their healthcare professional at baseline, and only 6 shared what they wrote in the Voicing My Choices at follow-up. So some quotes were, I haven't had an opportunity to have this conversation yet. I think they should raise it with me, not the other way around. So interestingly, suggests that doing the tool in itself is probably not enough necessarily to facilitate that communication with the wider team. They found no significant differences in perceived social support or acceptance of illness, but they did find that anxiety around end-of-life planning decreased significantly between baseline and then doing the tool and then follow-up. So anxiety actually about end-of-life improved. And over 90% reported the VMC items to be helpful and suggested some changes. So I think this anxiety finding is particularly helpful because a lot of the time, if colleagues or health professionals are concerned about having these conversations, it can be a concern that we're going to really destroy their hope or make them devastated or that they'll fall apart. And so just to flag that we've also been looking at this tool in Australia across a number of sites where, we decided that this tool was great and it needed a bit of a local adaptation. So over the past couple of years, we've been undertaking a multi-perspective evaluation of the tool to then tailor it for an Australian version and then pilot it. And so this paper here, we kind of describe some of our processes. And I guess just to say, we do kind of speak the same language, English, as they do in the US, but looking at the original tool, it really wasn't quite fit for purpose for an Australian clinical context. There was certainly language that just doesn't kind of fit, culturally for us, and also perhaps in terms of our healthcare system, which is quite different. So, for example, there were items to do with, whether you'd want to be able to hire and fire people in your medical team. But there was also just other language. So through 2 rounds of interviews, we kind of adapted the content and the language involved in the tool. For example, the spiritual section became more of a spiritual and cultural section, which was more inclusive and more appropriate in the Australian context. And we also got their thoughts on the graphic design of the tool. And so this was in the second stage of interviews with 17 young people. Just over half of them were female. And so here are some of the quotes. So this young person said, the picture on the cover just really reminds me of the clinical clinic room that has like forced nature imagery, trying to be comforting, but ultimately very unnatural. This person said, I don't know how I'd respond to it. I probably wouldn't think much of it. I think it's ugly. Yeah, it kind of makes me feel like I'm looking at a pamphlet at a medical centre. I don't think it's appealing to any age, but I do like the idea of water and clouds and sky, just maybe not the reeds and things. This person said, I think the kind of nature-based motif is lovely. I think maybe changing the font, it just seems a bit dated. This person says, I do like the dragonflies and that kind of thing because I know that dragonflies are really symbolic for some people. So what we took away from this is that firstly, unsurprisingly, young people have some very strong opinions, and unsurprisingly, we've got about 1 million different opinions. But we definitely, the consistent kind of message was that the graphic design of the tool could benefit from a bit of an updating and, making it a bit, not so much modern, but just updating it and changing it a little bit. So we did some work in partnership with Palliative Care Australia, Palliative Care Queensland, sorry, and in partnership with them, we were able to redesign the look of the tool as well, to sort of just be a little bit like not hit you over the head with Australiana, but just be a little bit more, I don't know, local in flavour. And this is what the tool looks like now. And it's got some new sections in it as well that are different to the American tool. And these were sections that came from young people's suggestions that we were interviewing. So stuff you need to know about me to give me the best care possible, my bucket list. Those are those new sections there. These are just adaptations of the original tool. This is a new section here, how I'd like my online presence to be managed. So what do young people do about all the kind of social media stuff and where that goes after they die, and kind of prompts for if they wanted to be able to write letters to anyone. And so I'm really thrilled that we're currently piloting this new version of the tool at the moment at Sydney Children's Hospital, Prince of Wales Hospital, Queensland Children's and Princess Alexandra, and potentially some more sites to come on board as well. And so that's really exciting because I think we're now at the stage of getting more kind of data to support the impact and the safety and feasibility and acceptability of the tool kind of in practice with young people currently on treatment for cancer. And so where to in the future? So I think one of the things to highlight, is that it is actually a standard of care in oncology that young people be able to access palliative care, and especially that they can access, so they should be able to access palliative care to reduce suffering throughout the disease process, regardless of disease status. And that when necessary, that they should be able to receive developmentally appropriate end-of-life care. So that's actually a recommended standard of care based on a lot of evidence. And so we need to think about what do health professionals need to be able to, regularly, consistently, and effectively implement that standard across all the different settings that we work. And so one of the studies that I've been really excited to lead most recently has been this global AYA Accord funded work, which we actually have kind of undertaken through COVID, but using a global survey to really understand what kind of training and support does the AYA clinical workforce need to feel confident, capable and skilled to be able to deliver this work. We're just in the analysis stage of that data, so I'm hoping to be able to get that out soon. But I think what we're hoping to do is really drill down on the particular skill sets that health professionals are feeling they need the most support around, and how they would most want and be able to access training to do that. And I think the other thing that I'm particularly passionate about is making sure that we can continue to break down silos in delivering this care. And I think, we know from the data that often these conversations are brought up too late, and sometimes they're only raised once the palliative care team is introduced. But we know also that the palliative care team is often not introduced until much later in the treatment trajectory as well. So I think it would be really great for us to think about new and innovative ways that we can be just harnessing the skill sets and the different complementary skill sets of everyone on the multidisciplinary team. So I'm obviously a clinical psychologist, so that's the hat and the perspective that I wear. And so, recently I was part of this group really advocating for the unique role that psychologists can bring to this sort of work, considering that it is so relational in nature. By that I mean that it just really needs to be built on the foundation of a really strong rapport and kind of a really excellent working clinical relationship. And so I think there's skills there that psychosocial staff can contribute, but also to contribute to help support colleagues. So there's a lot of things that a lot of different disciplines can contribute. And I think that in the healthcare system, we still don't always do the best job of breaking down those silos so that the different disciplines can be working together and supporting one another, and sharing how this work happens. I think that this is work that is only going to become more important as well, because while, we're very fortunate in Australia, we have fantastic healthcare, and the vast majority of young people diagnosed with cancer are fortunately going to survive these days. It's something around 88% on average across diagnoses. However, we also know that there's kind of an increasing group who kind of fall into this grey zone, who might have a poor prognosis, but might have many opportunities to kind of have their illness sort of managed or held at bay through a range of different kind of new treatments and experimental treatments, as well as precision and immunotherapies. And so I think the increasing complexity of what that medical treatment looks like means that I think we all need to be really adept at thinking about how do we support people, to cure them the best way possible. How do we support people to engage with their lives, if cure is going to be on the horizon, and also if it's not, and how do we help them live their best lives in the meantime, for whatever that trajectory looks like. So I'm going to finish up there in terms of the content of what I wanted to talk about, but I can see a number of really excellent questions in the chat, which I'm happy to dive into now. And I guess I just want to really thank you all for dialing in. And there's my email and my Twitter handle. I'm really happy for anyone to reach out directly or share any of the papers that I've mentioned. I also just want to really acknowledge my funding sources, Cancer Institute New South Wales in particular, and the AYA Global Accord, who funded some of that work that I spoke about. But yeah, thank you.
Hi, Ursula. This is Pip Collin. I feel like your ghost host. I'm sorry that I had technology problems at the beginning, but I did actually manage to catch the very first sentence that you started off with, and it's been fantastic to sit here and hear your presentation. Thank you so much, and congratulations on the work. It's been, I think, very important to hear sort of about the research that sits behind this, but also the very practical tools that you're developing with young people. And I couldn't help thinking as I sat here that this seems like a great example to me of where very careful research and co-design with young people could actually be setting the standard for best practice, not just for young people, but actually for all people, which I think is maybe where you started to end. But in any case, thank you very much. We do only have about 10 minutes for some questions, so I might dive straight into those if that's okay. We've got a few here, and I might start with one from Aya, which I think kind of goes to the last part of the discussion where you're talking about the role of professionals and I guess taking up and implementing the model and using some of the resources and the approach that you're advocating for. Are you looking at, or is there already work around how early career clinicians can be supported to have these conversations?
Yeah, so I think that's actually where I want to take that Global Accord work next, if I can, because the short answer is that I don't think we currently know what early career clinicians need the most in terms of doing this work. There's plenty of data to say that they probably do need more support and skills or training or supports to feel more confident and capable. I think that many professionals have actually fantastic skill sets, but it's actually the support to know how you're applying your training and skill set in particular situations. And I do think that there is something uniquely tricky for early career clinicians about treating a young person who may not be that different in age to you, who may be dying. And similar tricky things can also come up, maybe for older people who might have kids who are the same age as the young person who might be dying. So there are tricky things, across the board. But, currently, I think it's probably quite ad hoc and quite random how early career clinicians are supported. And that's certainly where I'd like to see that Global Accord work go next. In that survey, we've asked what are the kind of particular, exact skill sets and kind of skill processes that you want extra support, and what kind of training could you and would you access and use. And so we're going to use that to actually feed into hopefully then getting some funding to develop some training and supports, because I think it's really important to think about.
Yeah, it certainly seems like the kind of thing you'd want to increasingly embed in clinician training right across that sort of spectrum of professionals that are working in interdisciplinary teams. So Sharon asks, I guess, a slightly different but related question in terms of the role of parents and how, so taking, I guess, the kind of nub of the work that you're doing, that piece around conversations, really centering conversations and supporting those in the young person's life to have these conversations. What happens when parents and adolescents disagree, either about having the conversations in the ways that you're promoting, or indeed where there are disagreements that come through those conversations themselves about treatment or planning of whatever kind?
It's such a tricky area. I think what I would say is, so say if we're talking about a younger adolescent, like a 15 or a 16-year-old, where the parents are very involved still in kind of treatment decision making and things like that. I think that it's important that health professionals, talk to the parents about, I think sometimes they can use the research to help, guide a conversation, around, like hearing first what the parents' concerns are, and then also saying, we know from a lot of research that this can be the sort of benefits or the opportunities if we do have these conversations. And some of those leaders in the field that I kind of mentioned throughout today, they kind of talk about a couple of words that can be really helpful. And one of them is I wonder, and one of them is I worry. So I wonder what might happen if we were to ask Sally about this. I wonder what she might think. I wonder what that would be like, just to kind of hypothetical, kind of think about it. And then I worry. And if we use I worry, then that's when we can share, so hearing the parents' concerns and what their reservations are. And then you can say, I wonder what it would be like if Sally joined these conversations, and kind of talk about that. And I worry that if we keep this from her, then there might come a point where she actually wishes that she was part of the conversation, or we might be preventing her from being able to, say her preferences or things like that. So I worry and I wonder has been talked about really usefully as kind of words that you can use just to plant seeds. But I think, I guess it's just trying the best that we can to advocate for the young person's voice being in the room. And I know at our centre, we certainly try and have adolescents in the room as much as possible, but it is a tricky thing. And I think, likewise, I think Sharon's question is also sort of verging on the terrain of like when they disagree about treatment decisions and things like that. And that's really challenging as well. And I guess, the voicing my choices can be really helpful to kind of elicit preferences and to kind of have an external resource to look towards to kind of to guide some of those conversations. And there's also another really excellent tool developed by colleagues of mine called the Delta tool, which supports young people and health professionals and parents to kind of make decisions around early phase clinical trials in that kind of triangular way, and kind of helps sort out their preferences in terms of how that plays out. I see, is it all right if I just jump in? Because I can see there's conversations with brothers and sisters, and then there's a really important question about hope. Yeah, so I would say the conversations about brothers and sisters, I would say that probably depends a little bit on the family and the family system and how that family works. But, the idea, say, with the Voicing My Choices tool is that it's really up to the young person who they'd like to include in any of those different sections of the tool. And so there might be sections of the tool they really do want to share with a brother or sister. In our service, unfortunately, we don't always have the capacity to directly meet with all of the siblings, but it's really important that they can be included. And I think that, community organisations, places like Canteen, for instance, can often do some really great work with supporting brothers and sisters. But I think it's always worth opening that, like asking that question of the young person and the parents as well. Are there other people that you want to be involved in this conversation? Would you like us to be involved in any way to help broker that or help make that happen? They may not want us at all, but they might actually find it helpful to have a joint family session so you can explain stuff that they don't feel able to explain. And Alexander's question about hope is really excellent, and I think gets to the nub of why a lot of the time people don't want to have these conversations. And I would say to that, I think it depends on what you're hoping for, and there are many, many things that we can hope for. And I agree that sometimes it seems like our medical colleagues can be afraid that talking about palliative care will destroy the will to go through treatment. And I would also say that the data is increasingly showing that that's actually an unfounded fear. Like Laurie Wiener's study before showed that if anything, anxiety went down after doing the tool. So I think often what we can do by talking about the conversations is actually just give people a bit more of a sense of certainty and control amidst all of the uncertainty. And I think that, the leaders in this field talking about palliative care communication would say that there are many different ways that hope can look. And so hope for a cure is just one type of hope that we can hope for. And so I think it's not about destroying hope, but sometimes it's about kind of tapping into what that hope is and what it looks like. And we might need to be supporting young people and families over time to think about what else they might be hoping for if it's the case that it's looking less likely that their hope for a cure might be a realistic hope. We're all human, and anyone who's a parent, I'm sure, is probably never going to drop that hope of hoping that their child's going to be cured, or any young person's probably never going to, in their heart of hearts, have that 1% that's still hoping to be cured. And that's a really human thing, but we can have a diversity of hopes. And so I think that with our medical colleagues specifically, I think the challenge is sometimes that I don't like the tools they have are medical treatment tools. And so I think sometimes they may not feel comfortable to help or to know what else they can do that feels useful and meaningful besides the pursuit of that kind of medical hope. But yeah, it's an important thing. But that's where I come back to that idea of the dialectics that I introduced, the stones balanced on both sides, because I think you can have a hope for cure and you can have hope for other things, and you can be planning for different eventualities. Yeah, it's tricky.
Yeah, I think that point that you raise about ultimately the role that a sense of agency and a sense of being respected, being involved in a process, and what that means in terms of young people's sense of self, and their mental, and the impacts on their mental health is borne out in so much research in so many areas related to adolescent and youth and health. And so it's no surprise really that it's reflected in your research as well, and so important to, I think, reinforce. I think it might also be an empowering insight for parents and professionals as well, who may be feeling a little uncertain about taking up and opening up these conversations as you suggest, but certainly very powerful. I have one final question, if that's okay. I think we've got two minutes to go, but it sort of goes, it goes back to the questions, I guess, that have already been asked. But I guess it's one thing to support and encourage people to have conversations and to listen to what people have to say. But we know that it can be very challenging for adults and professionals who are used to certain ways of doing things and work within institutions that are very much organised around adult ways of acting in the world, to act differently and to take action on young people's views. Have you come across anything in your research that helps us to unlock some of the challenges that adults and other health professionals might face in actually acting on young people's perspectives or wishes when they might actually challenge some of the orthodox ways of doing things, particularly in this setting?
That's a meaty question. I think the short answer is that I think that that's exactly the kind of thing that I'm currently grappling with, and the sort of thing that I would hope to influence next, really. So I think that to say the work in developing the Australian Voicing My Choices tool, we're really excited about that, and we feel confident that it's a really helpful and useful tool. But we know that it's not enough to develop resources and to kind of drop them out and kind of hope that it's going to change everything. We know it doesn't work that way. Because the healthcare system is a really complex, multi-layered beast, and so I think that that's really where things, the next steps of where things need to go, and how do we break down those silos. I was really privileged to be part of a paper that Laurie Weiner led in 2014, thinking about how do we better train oncologists in kind of AYA palliative care stuff. And there were some really interesting models that I think that we could consider. And I'd be really interested in thinking about, how do we harness interdisciplinary training and kind of communication and dialogue so that we're kind of talking more with our, multidisciplinary colleagues about these sorts of things, so we're not kind of trapped in our silos. But yeah, I think that's where we need to go next. So once we have a sense of what training people need, we then need to look at what does that look like in the system. So I don't think I have a good answer to that yet, I'm afraid.
No, that's great, Ursula, and I hope that we all continue to hear your updates as you continue to do this work. I think that systems change piece is like the big question. You're obviously grappling with it. So we've run the clock down completely. Thank you so very much for being our presenter today, and please stay in touch.
Thank you so much.